speaker is Dr. Paul Brodwin, who was a medical anthropologist, assistant professor at the University of Wisconsin-Milwaukee, an adjunct professor of bioethics and medical humanities at the Medical College of Wisconsin. He's conducted qualitative research about lay understandings of population genetics, ethical decision-making in community psychiatry, and alternative healing in Haiti.
Good morning. Let me first say that I'm not a clinician. I'm a social scientist trained in medical anthropology. And for my entire career, I've carried out qualitative research on the forms of communication between patients and providers. So in my talk this morning, I'd like to look closely at what happens in the face-to-face encounter between healthcare providers and patients with IBS and related complaints. Now, I'd like to share with you one item in the basic toolkit of social science research in healthcare, the explanatory model. Now, the explanatory model as a term has been mentioned a few times, notably by Dr. Good at the top of the day. But with this tool in hand, we can analyze the complicated and often frustrating communication between healthcare providers and people with chronic conditions that don't fit into the standard diagnostic categories. We already know these diagnostic categories are a little blurry, and also that lack immediately effective therapy. So, my goals for this presentation. First, to talk about explanatory models, which is a basic framework that really goes back over 30 years in our field, medical anthropology. I'd like to talk about the key elements in patients' explanatory models for chronic conditions with medically unexplained symptoms, including IBS. I'd like to talk about how cultural factors affect explanatory models. So in a sense, what I'd like to do today is operationalize aspects of the talk that we just heard. And finally, I want to look at how this model can be used by physicians to reduce the frustrating types of talk and communication and to obtain better outcomes. The promise of the explanatory model literature is that eliciting patients' explanatory models and negotiating between them in the way that they differ from the physician's model is a strategy to improve clinical work. It's not a new technology, but it's a path towards a better kind of dialogue. And actually embedded in my talk today, or in sort of the second half, is a specific hypothesis about the value of learning the patient's point of view about the course of chronic problems. Okay. So, medical anthropology, as we've already heard, focuses on cultural influences in healthcare. And I think that it focuses on both large-scale, macro-scale, and micro-scale effects. So, very, very briefly, at the larger scale, actually, to take an example from the talk we just heard, healthcare disparities must be understood in terms of the bureaucratic and economic context of healthcare services. Healthcare disparities don't come about just because of racism. They come about because of the way institutions operate and have operated over a long period of time. That's precisely why they're so hard to reverse. Macro scale also at the macro scale would be the broad civilizational context of beliefs about the body, how illnesses are understood, the sort of idioms of distress that people use. But then there are the micro-scale influences, and that's really what I want to talk about today, this morning, face-to-face interaction at the clinical front line. Why is it successful? Why does it fail? Now, but the very word culture is too broad. Okay? Culture means far too many things to too many people. So how can we get a better handle on this process, on the process of how culture affects healthcare? Explanatory models are a window into this effect, and hence actually a tool for more culturally competent care, again, to operationalize that notion. And here's a classic definition from Arthur Kleinman. An explanatory model contains the notions about an episode of sickness, a single episode, right, and its treatment that are employed by all those engaged in the clinical process. So, for every episode of illness, the claim is, individuals, we'll start with patients, struggle to answer a few basic questions. And these are on your handout. There are 5 questions. What caused my sickness? Why did I become sick at this particular time? How does the illness work inside my body? What will happen to me? What will this illness do to me? And how should it be treated? Now, you'll notice that I use very non-medical prose here, right? I'm using ordinary terms. It's ordinary middle-class American English to drive home the point that ordinary patients are always engaged in answering these questions. From the patient's side, the process of devising an explanatory model starts long before they walk into your office. It continues long after they leave it. The explanatory model is something which people weave sort of over time and in discussions with many other people by drawing sort of in a, sometimes practical and maybe even scattershot fashion from all sorts of different sources of knowledge. People simply try to make sense of what is happening in their bodies. There's a baseline existential need. When the body starts to intrude on their consciousness, people struggle to put it into some meaningful frame. Now, typically, and unfortunately, patients don't reveal their explanatory models to the person treating them. They have the model, it doesn't come out necessarily. And I'll come back to that point later. Well, we could recast the explanatory model in terms that physicians use, and here they are. I don't need to go through it. The point is that physicians, now these terms, in a sense, correspond to the lay understanding of a particular episode of illness, and actually that's why I this morning after coming here and realizing there were no handouts, I quickly typed this up and had the hotel copy it. Because if you compare the two, sure, they seem to correspond to each other, but in fact they're used in entirely different ways. Most of the time, physicians, moreover, do not need to tell the patient about all components of their model. I mean, you may need to have it, and it's or in the back of your mind or the front of your mind in managing the case. You don't need to tell it. Now, maybe you know where I'm leading. The distance or mismatch between the explanatory models of provider and patient has the potential to distort communication, to obstruct therapeutic alliance, and to frustrate both sides. So there's a very low concordance between the explanatory models of the patient and the physician. Now let's explore this low concordance, this distance, this mismatch, first in general terms, and then more specifically in the case of chronic conditions or medically unexplained symptoms. To begin with the patient's model. Right. First, ordinary people build up their explanatory model to fit a particular episode of illness. So there is no single explanatory model of IBS. There's a different one every time a particular patient walks into your or begins to experience those symptoms. Think about it and talk to other people. The answers to those questions that comprise the explanatory model remain riveted to the here and now, to the immediate pressing problems and anxieties connected to their illness. Patient explanatory models do not deal in abstractions. They pose the questions and struggle towards the answers because people's lives and ability to live the lives they want to live are on the line. So patients devise explanatory models because they're pushed to do so. It's not out of a pure intellectual curiosity. They need to make concrete adjustments in the short term. In the case of chronic conditions, they need to follow the twists and turns of their symptoms and often to rethink their futures. Nowadays, of course, patients in the United States, many other parts of the world, routinely go to the web in an effort to diagnose themselves and learn about prognosis, likely course, treatment possibilities. Now, often the information they get, and I'm sure every clinician knows this, is a jumble, right? Not only because the web is a jumble, but also because the goal of coming up with the explanatory model is not a high-level systematic analysis. The goal is practical, to get the answers to what caused my sickness, what is likely to happen, how I can lessen the symptoms and their effect on my life. So no matter what information people take in order to build their model, they use that information in practical, short-term ways. Now, here is a outline of the ways in which the physician's model and the patient's model will differ. And this involves textbook knowledge on the expert side, expert for a physician or their healthcare provider. Textbook knowledge on explicit connections made between the different parts of the model versus a sort of informal logic, tacit connections made. When I say the expert's model is driven by the therapeutic imperative, I'm talking about something has to be done the next half hour. Some treatment recommendation has to be made. Tests have to be ordered. Anxieties have to be allayed, and it all has to be done, in the short term for treatment purposes. The patient's model it's also short term, but for practical needs that will continue to occupy him or her for often the rest of their life. Routine and emergency, the phrases I use there, comes from the classic sociology literature. The minimal definition of a professional, right, as someone for whom, someone whose routines are other people's emergencies. So that it takes a different, or that gives to the practicing professional a different orientation, a different way of using knowledge, a different tempo of work. The source of physicians' explanatory models are professional training and norms. As I said before, the source of patients' models are much more local. The forms of justification are different. I might say as a provider, I know something about the course of this problem. I know what is likely to happen. I know what the 5 possibilities for what caused it. I think I know what to do based on my textbook knowledge and my 20 years of practice. That's what makes me believe in my explanatory model. Patients have a different form of belief. Is it useful in mastering my symptoms today? Now, eliciting the patient's explanatory model is an art. Eliciting the model is not a time for patient education. It's actually time for provider education of a sort. The task is not to correct misinformation, not to replace a patient's emotional jumble of ideas with a cool, rational, systematic textbook truth. That may be an important task in general, but for the moment of elicitation, the task is to retrieve the patient's point of view in a framework that makes it usable for the therapeutic alliance. What's the best way of doing this? Well, it demands a certain attitude and a certain technique. The attitude is a genuine, non-judgmental interest in patient's point of view. This is a matter of clinical art, what used to be called bedside manner. Physicians, obviously, and you all know this. I don't know why I need to rehearse it. You need to learn the patient's explanatory model in order to plan the right treatment, especially in chronic conditions where symptom management and not cure is the ultimate goal. But in terms of technique, there are 8 recommended patient interview questions, and this is kind of a tried and true presentation of the matter, not at all original. And I wanted you to have it on your handout. Here's some questions which might be helpful in eliciting the explanatory model. What do you call your problem? What do you think caused it? Why do you think it started when it did? Right. What does your sickness do to you? How severe is it? What do you fear most? What are the problems it causes for you? And what treatment do you think you should receive? And what do you think, what do you wish to get from that treatment? Now, if you pose these questions to your patients, the details of the answer will differ in, I'm sorry, I should want to go back one second. Right. If you pose these questions, the details will differ in every case, in every illness episode, by definition. And even the same patient, the answers will differ over time as the symptoms amplify or dampen because of treatments, organic changes, or other life stresses. Now, let's talk about symptoms which have, or syndromes or symptoms with an ambiguous nature, which lack singular causes. Cases in which people's complaints cannot be fully explained by structural bodily pathology, and symptoms or syndromes which lack firm treatment guidelines. How can we apply the explanatory model framework to IBS and other functional GI disorders? Now, these patients have medically unexplained symptoms. And did anyone see last year, 2010, a fascinating article in the Journal of Psychosomatic Research with the title, "Is There a Better Term Than Medically Unexplained Symptoms?" A group of physicians in Europe held a series of meetings in order to come up with a better term. They believe that this term has deep problems because it's a negative statement, a statement of a lack. The term withholds from patients the affirmation which they most desperately seek, that their problems, in fact, have a name. Not they're just unexplained. They have a name, that it is a legitimate problem with a concrete explanation. The group systematically reviewed alternative terms and ended up preferring functional somatic disorder, actually. They like that term precisely because it's neutral with respect to mental or organic cause. The important point for us, though, is not nomenclature, but the way nomenclature makes face-to-face communication break down. Indeed, the entire rationale for looking at explanatory models is to improve the quality of care. Before this audience, I don't need to rehearse the familiar problems, the enduring difficulty that such people face. And let me just say as a footnote, by the way, a lot of my thinking here comes out of research that Byron Good and I completed many years ago on chronic pain. So this is I'm reading the literature a little bit through my own research experience with chronic pain patients. Individuals whose symptoms don't fit well into standard categories, laboratory findings are ambiguous or negative, the degree of objective disability and subjective suffering is not explained by positive findings. As a result, of course, they get told, and we've heard this already this morning, the problem is all in your head. The symptoms are trivial. They get told they're psychologically weak or neurotic, that nothing can be done, that functional GI disorders are a type of malingering, a search for secondary gain. Now, in the face of this recurring problem, explanatory models is not a panacea, but it can reduce the mutual distrust and resentment, incrementally, I think. To specify exactly where these two models differ and how great is the distance is a necessary first step. With such knowledge in hand, providers can negotiate an acceptable shared understanding of the illness. I mean, that's the goal, isn't it? A sort of space of overlap between the two models, which will allow the therapeutic work to proceed. A basis for a workable agreement about symptom management, adherence to treatment, lifestyle modifications, and the rest. Now, let's microscopically now focus on the fourth, just to show you how this might be done, and to justify the claim that it actually has clinical utility. Let's focus on the fourth aspect of explanatory models, which is course. And so question 4 of the explanatory model on your handout is course, including symptom severity, likely trajectory, acute, chronic, or impaired. Now, right. So these pose a question, how do patients understand chronicity, right? Does their understanding stay the same? Does it vary over time? Can learning, this is in line 4 on the model, can learning their explanatory model improve patient care? And I'm going to draw from a wonderful piece of research by a sociologist about the experience of chronic illnesses of all sorts, so it's at a high level. She claims, Kathy Charmaz, claims that there are actually 3 phases, sequential phases, in the way that patients with chronic illness understand the course of their disease. The first phase is interruption. When people first start to experience symptoms, they consider them a temporary matter, and they expect a full recovery. They cannot envision a life of unrelenting illness or permanent disability. As a result, people during this phase try hard to be good patients, following treatment recommendations, wanting to do the right thing, being, actually the very word patient, right? I mean, they try hard to be patient about the illness and patient about the treatment. right, so they do not relinquish a premorbid sense of self. Now, the implication for the caregiving encounter is actually, wow, I mean, this is a time when caregiving, in a sense, is easy. I mean, diagnostically may be difficult, technically might be difficult, but in terms of the face-to-face communication, it's likely to be smooth. The patients want to do the right thing, and they're willing to listen to you as to what the right thing is. Now, as time goes on, and as patients get more experience with their illness, the finding of the sociologist is that they enter a second phase in their understanding of chronicity, which she calls intrusion. As time goes by and the illness is not cured, people are forced into another kind of adaptation. They start to regard their symptoms not as a brief interruption, but a constant intrusion into their lives. In this phase, people learn to expect symptoms and to plan around them. They learn, usually by trial and error, how to manage the cycles of exacerbation and quiescence. And here's an excerpt from an interview, actually, with a patient during the intrusion phase. She says, "I'd rather be making a lot of money, etc., but I've reached a balance, and I've accepted the illness and I'm working around it." The researcher asks, "What does that mean to you?" Acceptance, accepting that I'm not what I used to be. So this is a turning point. I mean, this is qualitatively a different way of regarding your symptoms. And that's right. This is a phase of reconciliation, of accommodating oneself to the illness as a continual presence. Now, it's not a peaceful phase, because the question always nags people, can I keep the illness in the background? Can I control it, or will it control me? In this phase, people actually have not settled on a single answer to the question about course. Okay, so remember, we're still talking about explanatory model. Number 4, the course. The question about course is here unsettled. And the implication of here, I'll come back to this, is that this is a time actually to renegotiate expectations and to build alliances. Unfortunately, that time ends. That phase ends and gives way to a third phase, which she calls immersion, the sociologist. For some patients, reconciliation gives way to immersion. In this phase, people reconstruct their lives around their illness. They move beyond a tipping point. They plan their lives fundamentally around the illness. They can no longer keep the illness in the background. In a sense, their pain, discomfort, and disabilities shrink their world. They don't look beyond their illness in order to make plans or to make major life decisions. They pull back from all relationships and commitments besides those of caretaker or medical provider. Now, here's my point, to translate my point in a very crude way. You, as a provider, can stage the where a patient is in this three-phase course. Just like if you're an oncologist, you stage a tumor. You can stage now where are you at with this long process of coming to grips with it. So, I earlier posed several questions. How do patients understand chronicity? Does their understanding stay the same, or does it change as you learn more about the illness? How do they answer the question about course? And how can learning their view improve patient care? So let me now talk about improving patient care. Depending on how one understands the course of illness, how the patient, that is, understands it inside the explanatory model, different strategies of care are possible. Now, the first task, of course, is to elicit the explanatory model to figure out which phase the patient is in. The second and third phases, I think, call for specific approaches. Recall the suspicion and mutual frustration that physicians often encounter with people who have chronic conditions without clear organic findings. Now, the frustration doesn't begin in the first phase. The frustration begins in the second phase. In the first phase, people are adherent. They're trying to follow doctor's orders in full hopes of a complete cure. In the second phase, they become acutely sensitive to the possibility that they, in fact, will not return to their old symptom-free lives. This is when patients become furious, when they think their physicians are giving up on them. Now, this is when I think providers skate on very thin ice, and it helps to know when the ice is getting thin. When people's greatest fear is that the illness will overtake them, they most easily misinterpret their providers to mean you will never get better and there is no cure. like the fear leads to the misinterpretation. When people are trying to reconcile to their physical discomfort and lifelong disability, they are not ready to hear necessarily about psychological contribution to their symptoms. See, this is one of the strongest lessons I pick up from my long ago chronic pain work. Now, the very word functional can raise a red flag because it seems to undercut the very thing in which people are trying to adapt. Now, taking the right approach when patients understand illness as intrusion will have at least two benefits. At least this is my hypothesis, which I offer to you. First, establishing a good alliance with patients at this point can become a bulwark against the immersion phase. The immersion stage, the third phase, is to some extent the default option, the final default option. But I think the intrusion phase in the patient's explanatory model comes closest to the physician's understanding of chronicity. Let me state my hypothesis a more clear way. There is a critical period in the patient's developing experience of conditions like IBS. From the patient's side, we've labeled it the second phase, from interruption to intrusion to immersion. From the provider side, perhaps we can label it the second phase in a trajectory from denial to realistic reconciliation to giving up. This critical period offers a possibility of frank dialogue and alliance building, an opportunity that does not come often and does not last for long. Well, hope you will forgive me for ending my talk with a hypothesis and not a conclusion. Thank you very much, and I look forward to your questions.
Can we have both speakers?